The progressive muscle relaxation releases muscle tension induced from the fight-or-flight trigger by promoting blood flow. So each time you tighten and release your muscle, what you're doing is you're contracting and you're releasing your blood. I mean, not your blood, your veins, your capillaries. Yes?
Are you saying that the cardiovascular benefit you get is from whether or not you breathe from your nose or your mouth?
I'm sorry, can you read?
Are you saying that whether or not you get the cardiovascular benefit of slow diaphragmatic breathing is whether it's through your nose or your mouth? I'm a little bit confused what you're saying.
What I'm saying is patients who are experiencing a panic attack
Right.
rarely breathes through their nose.
I don't think that's the critical factor. The critical factor is if they're breathing from most people hyperventilating are thoracic breathers or chest breathers
Right.
instead of belly or belly breathers or diaphragmatic breathers. What happens if you're a thoracic breather, you're blowing off too much carbon dioxide, so the system doesn't make good hemoglobin, becomes less efficient. So whether it's the nose or the mouth doesn't matter at all. All the nose does is it purifies the air. The critical factor, as I understand it, is if you're breathing in the diaphragm, the CO2 oxygen ratio is 5 to 1, which is what it's supposed to be.
You're absolutely correct. However, if you're breathing through your mouth, you can't possibly get the deep diaphragmic oxygen that you can through breathing through your nose.
I don't agree with that at all. I can show it to you.
Okay?
Watch. Very simple. Whether or not you breathe from your nose or your mouth, everything's got to be down here, right?
Yes.
So watch this.
Sure.
She's saying in the context of a panic attack, people are hyperventilating.
Yes, that's
That's
When
There's
a
no
person-
difference though. It's not whether it breathes between nose and your mouth.
when a person is having a panic attack.
Yeah.
What they're doing is they're hyperventilating.
And they're breathing from the chest.
And they're doing it from the chest, but do you think they're breathing through their nose?
It doesn't matter. It doesn't make a difference. It's not the nose or the mouth is not the critical factor. It's whether you're using your chest or your diaphragm.
I understand that, sir. That's not what I'm saying.
Okay.
What we're doing is we're changing the person's behaviors,
Right.
right? If we tell the person to just breathe in and out out of your mouth,
Right.
in the face of panic, and maybe you weren't here for this,
Right.
their ability for rational thinking is not there. And therefore, they will just revert back to their old automatic manners in breathing. If they think that to breathe, I have to breathe through my mouth, they're just going to keep breathing, hyperventilating. They're not going to be able to think, oh wait, I gotta do this and put one hand here and put one hand here and breathe in through the diaphragm. However, wait a second, however, if you teach them to breathe in through their nose,
Yeah.
you're teaching them to slow down that breathing so that the air can get into the diaphragm rather than only in your chest.
Well, when we have a lot of success, I think people breathe with straw. You
Yes,
have to use your mouth and not your nose, of course.
yes,
And that works great.
that works great with one.
Using a straw. Because
Okay.
sometimes when people hyperventilate, they gas.
That is right.
So with a straw, you can modulate it. So it's 5 seconds in, 5 seconds out.
Sure.
Just like yoga breathing, which very often can be from the mouth.
I think the point is just shallow breathing versus deep.
That is
You're right.
Dependent, especially for people that have like,
Deviated septum.
what is it called?
Deviated septum, when you can't get
And
air
there's
into
also
the
a throat condition that requires people to breathe through their mouth as well.
So that is the only difference. It's the difference between shallow breathing and deep breathing. And when panic patients are so accustomed to breathing in and out through their mouths, teaching them a different way to breathe in through their nose is a new behavior that is much easier to adapt to than trying to get them to understand, well, you can still breathe in through your mouth, you just have to breathe in differently. Makes sense?
Yeah, I think that most people, when they teach diaphragmatic breathing with biofeedback, we use a strain gauge around the diaphragm and EMG on the squeezes muscle, and these actually stop moving. That's why most people that hyperventilate have tight neck and shoulders.
Sure.
They have cold hands, tight neck and shoulders, and they yawn a lot. Those are the three questions you ask to try to assess whether or not somebody's hyperventilating.
Okay. Well, we're not talking about biofeedback right now. We're just talking about strategies to prepare the patient for interoceptive exposures.
I understand that. All biofeedback is just a monitoring mechanism, not a treatment mechanism. That's all.
I understand what biofeedback is, sir. Thank you very much. Okay, I'm going to move on now. All right. So we have the relaxation training to prepare the person for panic disorder. Was there another question out here? No. To prepare the person for interoceptive exposures. And the interoceptive exposures isn't for the dental or medical fear, it is for the panic attacks. And why again do we need to address the panic attacks before we can address the medical or dental fear? Because we got to target the internal cues before we can target the external cues. Okay? Yes?
You say that dental phobia, if you are severe anxious, it leads to a panic attack. But as being a dentist working in a fear clinic, I find only a minority of my patients, they have real panic attacks. I think only 20% of them. The rest stays in a state of hyperarousal, so that they continue breathing in a normal way. So I think a panic attack is not a result of a dental phobia. So I think it's a comorbid disorder which can complicate the dental treatment.
Right.
But
Right. That's what we were saying. Is
It's
that
not everybody.
is
She's saying it's not everybody.
oh yeah, so maybe I.
right. That's what we were saying earlier. Okay. So then we have to do mindfulness training. And the purpose of mindfulness training is to increase your awareness of your physiological sensations and to decrease the avoidance of discomfort. A lot of people, when they experience the panic sensations and it doesn't feel good, what they do is they mentally escape rather than focus in on the physiological sensations. I have a patient who started out having fears of dentists and having cleanings, regular cleanings and so forth. However, because of this fear that triggers panic attacks, eventually over time he started fearing his internal sensations, and the panic attacks developed into panic disorder. Okay? So this is again classical conditioning now. And because he was experiencing panic disorder, he became so severe that doctors started putting him on Xanax, and by the time he came to us, he was on about 4 milligrams of Xanax a day. Now, you put me on half a milligram of Xanax, and that will knock me out the whole entire day. So I don't know how this guy functioned on so much Xanax a day. What happens is that because the Xanax becomes a buffer to the fight-flight response, what is he doing? He's gaining relief from the fight-flight response. He's avoiding the fight-flight response and experiencing relief. By the time that we were able to titrate him down to 0.75 milligram of Xanax, and he was doing more, and we got him to start exercising again, his very time going back on the treadmill, he said, I couldn't do it. Why? Because I was having a panic attack. What do you mean you were having a panic attack? Well, my heart just started beating really fast, and I was having difficult time breathing, and I could just feel that the panic attack was coming on. Well, wait a second. You were on the treadmill, yes. What level were you going? A 6 out of 10, okay? And how long have you been on the treadmill? For about 30 seconds. Okay, so when you're on the treadmill, isn't your heart supposed to beat faster? Aren't you supposed to be breathing more? So your body is basically doing what it's supposed to be doing, and yet you're appraising it as a panic attack, right? So a lot of it is training patients to be mindful of their bodily sensations so that they associate it with the correct event rather than, oh, I'm going into a panic attack. No, you're not. You're exercising, your breathing is supposed to increase, your heart is supposed to beat faster when you're exercising. Okay? So that's what the mindfulness trainings do. There are mindfulness meditations, and then there are strategies to enhance your ability to be mindful. I think a lot of you know what mindfulness meditations are, so I don't need to go into that. However, a couple of strategies to increase your ability for mindfulness. A lot of times I ask people to use the bird's eye view, which is basically imagining yourself from a bird's eye view, and you're watching yourself. And you're observing your 5 senses. Again, that is the whole point, is to bring awareness, the 5 senses that you have. So you're observing what you're feeling tactily, what you're smelling, the air in this room, the sights, the colors. And the more you practice that, the more you learn to be in the present and to be able to identify and understand the use of the 5 senses. Okay? There's also mindfulness eating and walking, which basically means you're going to take a walk. However, you're not going to be on your phone texting, or you're not going to be talking to someone while you're walking or eating. You're just going to do it and pay attention to that exercise alone. And when you're walking, you're supposed to be experiencing your internal cues as well as observing the external environment. So feeling what your body, what muscle groups you're using, how are you walking, how do you balance your body, noticing the colors and the smells and whatever you see. Eating, very powerful senses for your smell and taste. Okay, seeing if you can smell the food, the ingredients in the food before you actually taste it. And then when you taste it, it's not just about flavors, it's also about texture and temperature and so forth, right? Okay, then the next one I use is shoulds and buts. Some of my staff members actually hate this one, however, I like it. What I basically have patients do is I have them carry around a notebook, and I ask them to divide it into 2 columns, one for should and one for but. And whenever you either think the word mentally or say the word verbally, you're to give yourself an X in that respective column. Now, a lot of people may ask me, well, why the words but or should? You can use any word you want. However, the words but and should really don't deserve a place in our vocabulary. The word but negates, right? It negates what you say, so why say it to begin with? A lot of people will start sentences with but, yeah, but, and it's used as a defense mechanism, okay? The word should, it's basically just criticisms, whether you're shoulding someone else or yourself or an animate object, what you're doing is you're placing judgment. So by having you focus on these words, again, what you're doing is you're bringing your senses in the present moment, okay? And then oh wells is basically being able to accept and let go those situations that are out of your control. And the truth is that most situations are out of your control. The only thing that you can control is what? Do you remember the 3 levels of functioning? Your behaviors. That's the only thing that you can control, your own behaviors. You cannot even control your own emotions or the type of thoughts that you have. You can only control your behaviors and how you respond to the thoughts. So you cannot control what might happen at the dentist's office. Okay? So allowing it is basically letting it go because you know that is out of your control. It's a false sense of identity. Yes.
Can I go back to the habituation? Do you usually do all these things within a session?
No. This is progressive. Yes.
And
So,
habituation, though, since it's up to a period of time, multiple exposures and
what you would need to do first before you do anything is the relaxation training. Because in doing the relaxation training, what you're doing is you're preparing the person for interoceptive exposures. Okay? And again, the interoceptive exposures target internal cues. Okay? And mindfulness training helps them to experience those internal cues rather than avoid them. That is why you do relaxation training and then mindfulness training to prepare them for interoceptive exposures. After the person is able to go through all the various exercises in interoceptive exposures and they're no longer in a state of panic every time they're experiencing a fear, then we can expose them to the external cues of people, places, situations that will trigger the anxiety.
But if your assessment has revealed it's mostly external cues, you don't necessarily do all this.
Yes,
Right. So it's just external.
yes. Uh-huh.
So after you do the relaxation training to prepare for the interoceptive exposures, how do you incorporate the two? And some people view the relaxation as more of a safety behavior. So
Right.
can you comment on that? We actually heard a presentation earlier where the presenter gave some pretty powerful research to show that pure exposure has better effects than
Absolutely.
exposure combined with the relaxation.
Absolutely. When we do interoceptive exposures, that is the only time that relaxation exercises are used.
But he's saying exactly not to do it in terms of, if you go to APAA, you hear different things and different
Sure, but he had some pretty strong
data
research
that
that,
add relaxation.
yeah.
You don't get
we were
relaxation.
saying-
Yeah.
the relaxation behavior.
For panic attacks,
Yeah,
for
correct.
interoceptive exposures, or for in vivo
It was
exposures?
particularly for,
Yeah, and he showed us videos of spinning clients in chairs and breathing through thin straws and so forth. He said, do not do relaxation before you do this, it weakens the effect. It may work a little bit. But
Okay.
you're going to get a much more powerful effect when you just do the
so
exposure.
there's the debate, we feel.
Well, I mean, I would definitely be interested in looking into this research because what previous research would indicate is that if you don't do the relaxation exercises, because panic occurs in such a short time that when you don't do the relaxation exercises to the exposure of the internal cues, then what you're doing is you're just exacerbating the panic attacks.
So the debate would be that if you can't bring on relaxation when you're in panic, then you panic more, and you have to know that you can't, that you'll be okay even if you can't relax in the context of the panic.
Flooding. It was active flooding versus gradual.
Right. Flooding is different from
Yeah,
interoceptive
that's
exposure.
that wasn't quite it. Yeah, that wasn't
The
exactly-
study
The
was,
person you're talking about is called the Pullman process by Andy Solomon.
I don't,
And it was the idea that if you, what you're saying.
let her do the presentation, I think it's really.
No, it's important what she's saying. The reason that your point is correct and your point is correct is because of the Pullman process. What you're saying, and I believe to be true, is the relaxation primes them in a certain way, or preps them. Serves like as a counter-condition model.
Right.
In your model, we're talking about when using flooding without relaxation, the spinning stuff you spoke about, that's.
It's very flood. He says you can do it gradually or slowly. It really
There was
matters.
just one good study that basically was interoceptive exposure with and without relaxation and looked at long-term outcomes over a year. And they had different effects. Both were effective, but interoceptive without relaxation was better.
And I would want to see, was there any type of preparatory work, psychoeducation, or any type of preparatory work that occurred before the interoceptive
Oh,
exposure?
definitely.
Education, yeah, education and exposure,
Just not relaxation.
just not relaxation.
He sort of thought there was no place for relaxation at that
Okay.
time.
Well, I'll be very interested in seeing that research. However, the theory is that because the person going through panic attack, it's a sudden onset of your fight-flight response, that having the skill of decreasing that fight-flight trigger helps the patient feel a sense of control rather than out of control. So, I would want to look at that research before I comment on that at all, okay? So, you want to help the patients go through symptoms of a panic attack in a controlled environment, and it teaches that the internal bodily symptoms need not develop into a full-blown panic attack. And it induces on focusing, inducing actual physical sensations that is experienced during the panic attack, and then relaxation to control that fight-flight trigger. And once the patient is able to understand that the panic is separate and independent of the frightening internal and external cues, then the panic itself begins to lose its power. So a lot of times, we have these procedures such as spinning in the chair, running up and down stairs, straw breathing, hyperventilating in a bag, and the purpose of all of this is to get the person to habituate to the sensations of panic, to get the person used to the sensations of panic so that we are revaluing their misconception of the dangers of these sensations, okay? And after each exercise, patients learn to apply the relaxation training to return their fight-flight response back to baseline. And then what we do to increase mindfulness is that we ask patients to compare self-induced versus uncontrolled panic symptoms. So we want them to compare the two. Oftentimes, we can just go into a situation, for example, we can, a person with a panic of dentist, I can just show them a picture of dentist and they can have a full-blown panic attack, and then they can experience the difference between what it's like when we do it in this controlled setting versus what happens when it's sudden. And usually what they'll tell you is that there really isn't a difference in the bodily sensations. What the difference is, what you understand externally, what's happening. Now, what I tell a lot of patients to do is, if a panic does occur unexpectedly, then the goal is for them to get right into one of the exercises that mimics the same sensations. So for example, my patient who is afraid of the treadmill, well, what I might have him do is get off the treadmill and start jogging in place, running in place. Because what that is that it is the same as the interoceptive exposures. And what he's doing is he's still increasing his cardiovascular activity, increasing his heart rate, and decreasing the level of the amount of oxygen he's able to get into his system, and experiencing the same sensations. And by doing that, then do the controlled breathing, the controlled progressive muscle relaxation to calm down the fight-flight trigger. And that way they learn to take control of the sudden panic attacks that occur.
I'm curious, it sounds like you do work with people with medical illnesses.
I'm sorry?
Don't you work with people with medical illnesses?
Mm-hmm.
How do they receive or the care that you use when doing the IE exercises? Just if they're in fragile health.
Right. Well, there are many different ways that we don't have to, that is just a guideline. You can always tweak whatever these exercises are to bring about the same result. So if I want a patient to, let's say the patient is wheelchair bound, and we want them to increase their heart rate. Just raising your arm above your chest is going to increase your heart rate. So you have to also keep in mind that patients who are hypersensitive to medical dental phobias and hypersensitive to their bodily sensations are going to notice the slightest changes in their bodies. Okay, so you don't need to throw them into on the stairs. You can even have them walk back and forth, and that will increase the heart rate. Okay, and you want to match the exercise to the person's level. The person may not be ready to go spinning in a chair for 60 seconds. You might just want to have the person spin and walk in a circle for 10 seconds to start out with. Okay? So the results of interoceptive exposure, the most important is that it disrupts or weakens the association between specific internal cues and panic reactions. So I understand now that my body is just reacting the way it's supposed to be reacting. It doesn't mean I'm having a panic attack. It doesn't mean I'm dying. Okay, that's the most important. Okay, let's keep going. So then what would we do after the person is able to take control of their panic attacks if panic is associated with medical dental phobia? Then this is when we do the systematic full sensory exposures to their internal cues. And again, the goal is to correct faulty assumptions that they've given to these situations. So visuals, I might have a video loop tape of a medical or dental procedure and I'll have them watch it. The goal is to mimic the same situation as much as possible. I might put a bright light right in their face to resemble that light, the dentist light. I might have some of my staff members wear these horrible masks and surgeon suits or a white lab coat. I might even pretend that we're all touching the patient's face and trying to get at his or her mouth. We will have sharp objects, sharp dental objects. We do have a dental kit that we, have the patients touch and look at and be familiar with. Patients who are afraid of the tourniquet or syringes, stethoscopes, we'll have them use it on themselves, use it on other people. The goal again is to get them familiarized with these situations so that way the fear itself is reduced. The triggers no longer have the power that they originally had. For sounds, we can always get video clips of the drill, scraping sounds, heartbeats, EKG monitors. Tasting, well, we can have metal instruments that we actually put into the person's mouth. Sometimes what we do is we use the latex gloves for the gag reflex, and what we also do is sometimes we might stuff a latex glove with like paper towel in it and to put into their mouth so it feels like they're restrained. We are trying to figure out how to get the taste of iron in blood, and we try taking iron pills and mixing it with like red dye, and we're still working on that. So if any of you have suggestions of how to mimic that blood taste, let me know. The grainy mint polish, you can buy that, or you can also take toothpaste with baking soda, mouthwash. Tactile sensations. The mouth guard. Again, you can buy mouth guards at any sports store and put them in the patient's mouth. You can also use that paper towel example that I have. Reclining chair, that's easy. Blood pressure meter. You don't need to have a real blood pressure meter. You can always just tie, although you can get one, it's not expensive. You can tie like a tight strap around their arm and have like a squeeze stress ball and have them pretend it's like a blood pressure meter. We have syringes around and tourniquets.
Actually inject the person, that's where I get to. I get to the point of work with them where they can tolerate the needle coming out, the sensation on their skin, everything. The minute we put the needle in, these kids will punch you in the face and run out of the hospital. I can get that far, but it's kind of bridging on medical kind of practice to practice actual puncturing.
Right. Well, we don't do that. We actually take patients to a medical physician who would do that.
They'll do the actual.
Yes, who will actually do the puncture. So we have a lot of medical physicians in our building that we work with as well, that will simulate these types of environments for kids as well as adults. Yes.
When you do the treatment together, for instance, the doctor injects and you help the patient with
Yes, we
relaxation.
walk the patient through it. So we tell them, so, the needle is now going to be close to your skin, and now the needle is going in. You're going to feel a slight pinch. I mean, a lot of medical technicians are trained to do that now. With kids, you just need to be a little bit more specific with them. Because again, their mind is going to be ruminating about the uncertainties of what if, what if, what if. So again, your job is to help them through that. Yes?
As you're helping them back to sort of the relaxation question, are you saying as the needle's touching your skin, take deep breaths? Or are you saying
No,
let it
we're
be
not doing that at that
Or
point.
you're not talking about
No, we're not doing that at that point, because by this point, their panic attacks are taken care of from the interceptive exposures. And, it's natural for us to experience a little bit of anxiety when we have a needle coming at us. So we want them to have that experience. What we want them to also learn is that it's not a catastrophic event.
So what do you actually say during that exposure? Anything or nothing?
No, we say the needle is coming to your arm and it's getting close to your skin right now, and it's going to go in. You're going to feel, a little pinch. It might hurt a bit. You're not going to die from it. It's not going to be the end of the world. Yes.
If you go to girls that try, they have these blunt needles now.
Oh.
But they actually, and fluid will come out of them. They use them for QEEGs to fill the surface electrodes.
Uh-huh.
So if you use an alcohol pad on the skin and put it there, you'll get a lot of the same effect you're talking about.
Oh, well, that's good to know. Thank you for that. And then, we also have a straitjacket where we put on patients who have that fear of being restrained. So sometimes we'll put the patient in a straitjacket, we'll put them in a reclining chair and they can't move. We've got this gag thing on their face, and we have also made cardboard box coffins for people who are afraid of MRI. So we get these white cardboard, and we just make a coffin, and then the person goes in it, and we talk them through it. We simulate it's a real MRI, and they have to keep still, so forth and so on. Yes.
Maybe it comes later, but I wonder, since many patients with dental phobia, they had a lot of traumatic experiences in their life. For instance, childhood abuse, or they suffer very often from PTSD symptoms or even dissociative disorders. How do you, because what I notice in my practice, they have often flashbacks, and they are based on events of the abuse, and they are accompanied with a sense of helplessness and loss of control. The dentist is only another person which gives them a sense of loss of control. How do you treat these patients?
The dentist at this point is secondary. The primary is PTSD at this point. We got to treat the PTSD. There's no point in treating the dentist if the dentists are going to be engaging in behaviors that are going to remind them of an abuse situation. So the diagnosis for that situation may not be medical phobia, would be more like PTSD. I'm sorry?
Often it is, they have, for instance, fear of needles.
Sure.
They also have PTSD,
Right.
so you would.
I would treat the
for-
PTSD.
Yeah,
Yeah.
and that's for that, the fewer needles, for instance.
Then I would treat the needles. However, there are two separate reasons. You know, a person with a fear of needles, well, do they have a fear of needles because they had a really bad experience with a pediatrician? You know, where it hurt really bad and there was a lot of blood, more so than just, you know, a drop. That's different than someone who was tortured as a child with needles. And how the person experienced that trauma will determine what treatment it is. If the person is afraid of needles because it reminds them of the trauma, what you've got is PTSD.
And how do you treat it?
Oh, that's a whole separate talk.
Yeah.
That's a whole separate talk, right? That's another 2 hours. And then what we do after we correct the internal cues, we then correct the external cues. We do prolonged exposures to external cues. And the goal is to get correct feedback that changes the belief system of danger and fear. So when we want to start with imaginal exposures, however, again, because this group of people are great avoiders, it's only going to be limited. However, if you have a patient who's unwilling to go straight to the dentist, you're going to need to do it through imagination first. And what we would do is we would have them, we would play, for example, a video clip without the sound. We'll play a video clip. We might have them write narratives about a dentist situation and then have them record it on the loop tape, have them listen to it as they're watching. You know, this occurrence happened with someone else on the video. And when we're doing loop tape exposures, what we do is we always do the worst case scenario first. Because that's what the patient is fearing. They're fearing the worst catastrophic possibility.